I would like to introduce the next speaker, who is not a stranger to us, but our own dear Minister of Health, Honorable Dr. Frank Anthony. Dr. Anthony is a public health specialist for a number of years. Dr. Anthony has been with Ministry of Health for quite a number of years, participated in a lot of projects. At one point in time, Dr. Anthony was in charge of the health sector development unit, which continues to work in taking the agenda of health forward. The topic of mental health is one that Dr. Anthony is very passionate about, as well as all that has to do with non-communicable disease. And with that, I invite Dr. Anthony to the podium to provide us with the keynote address on our Guyana Mental Health and Well-Being Conference.
Thank you very much, Dr. Hamilton. Professor Paloma Mohammed, Vice Chancellor of the University of Guyana, Dr. Emmanuel Cummins, Deputy Vice Chancellor, Dr. Alexandra Harvey, the Head or Director of the Institute of Postgraduate Training, Dr. Christina Hoven, Head of Psychiatry at Columbia University and the Director of this particular program, the team from Columbia University, staff of the Ministry of Health, members of the media. I think we were just given a treat by Professor Hoven about the global situation as it regards to mental health, and in particular in the area of suicide. And that was then broken down to what is happening here in Guyana. But it didn't stop there. What we were able to see is how to dissect what is happening here and perhaps to do more interactive programs that can really address the needs that we have here. Suicide, as you can see, is something that has been plaguing Guyana for many years. And over those years, we have attempted to understand this problem. And there were previous studies that were done, some by local physicians, others by sociologists, and others by the University of Guyana. And each of those studies, we got a little bit of insight. And based on those insights, we tried to alter our programs, come up with something that we can use, hopefully, to affect those horrible numbers that we just saw. I recall one time Professor Kendance out of the University of Guyana did a study, and among the things that he showed that there was a connection between race, religion, youth, and location being in rural communities. And I think that then gave us an insight, perhaps, how to start addressing this problem. But after about, I think, 3 5-year plans that we had in suicide prevention, as you can see, the numbers are still climbing. And we really need to think about other ways of how we are going to affect those numbers. Certainly, whatever we are trying, while they might be helping in some ways and in some regions, it is not helping us to bring down those numbers as quickly as we would like them to. And that is something that I guess we'll have to keep working on, because nobody wants to see so many persons ending their lives in Guyana. We have, over the years, also attempted to create a more enabling environment in which we can do research, in which we can also, be able to practice maybe the things that we need to do to prevent suicide. When you look at our laws are really dated. Goes back to the time of the British and even, in the 1930s. And you might know that part of those laws, if you attempt suicide in Guyana, then you can be jailed for at least 2 years. and that is still on the books. We haven't used it for a while, but from the stats that you've seen, for every person who commits suicide, there are at least 20 persons who would have attempted suicide. So technically, if we have 147 persons who died of suicide over the last year, then multiply that by 20, and you can see how many people would have ended up in jail. That obviously is not the way. And while those laws at that time, perhaps persons were using it to dissuade people from committing suicide, I don't know how effective it would have been, because many countries that impose those laws have since changed them, but we still have it on our books. And there have been attempts and there have been discussions for us to change those laws, but things seems to be moving too slowly. I recall maybe about 4 years ago, there was a discussion in Parliament when PAHO was trying to take the lead on raising awareness on this matter. And we had a discussion in Parliament about how we can change this. But I guess 4 to 5 years have elapsed, nothing has happened. Over the last couple of months, however, I've spoken to my colleague at the Attorney General's office, Minister Nandalal, and we have been able to do a draft suicide prevention bill. And hopefully we can get that on the parliamentary agenda. And if we do this year, then we will be able to pass it and change those all things that have been there that does not really create an enabling environment in how, what we need to do to prevent suicide in Guyana. So with your support and with persons asking for this and championing this, I am sure we will get a change. So this is one of the things that we would like to do for this year. In addition to that, going back to laws dealing with mental health, they have been particularly problematic. One, in the way that they classify mental health illnesses, psychiatric illnesses, they're totally outdated. Some of the terminology that is being used are not in keeping with what we would like to see in a modern mental health architecture, if you like. And these things have to be changed. And again, there have been attempts for us to develop special laws relating to mental health in a good way, not to stigmatize anyone, but to create that enabling environment, to put better rules in place that govern our mental health institutions and so forth. And the first attempt was made in 2011. And while we had a first draft to work with, nothing happened since 2011. Again, that was picked up, I think, in 2017. And more recently, we started working on both pieces of legislation just a couple months ago. And we found that the two pieces are totally dissimilar. There are strengths in the first one in certain areas, and there are strengths in the 2017 version in certain areas. And then there are lots of weaknesses in both. And so we thought that we need to bring them together and to take the strengths from each of them, and then where we see weaknesses to come up with how we will be able to develop a better document. And so that document has been in circulation to various stakeholders. We have started to receive comments, and we now have a new mental health draft bill. And again, we'll circulate it to make sure that everyone would be able to have an input into this new bill. And so from the side of the government, we are very much interested in creating that conducive, modern mental health framework so that our practitioners, our clinicians, social workers would be able to work in this new framework. And I'm hopeful that we'll be able to move that piece of legislation to Parliament because I think a lot of people are very receptive to us having such legislation. And conference like this would certainly help to raise more awareness on the need for such type of legislation. But apart from legislation, again, over the years, we have tried to come up with different mental health plans. We had a plan on mental health from 2015 to 2020. And again, when you review some of the things that we're supposed to do over these 5 years, how much of it have we been able to accomplish? And PAHO did a review for us, and I can say to you, a lot of the aspirational things that we had back in 2014, 2015, when this plan was being put together, over the last 5 years or so, not much has happened. So there are good things that people came up with. We had all these consultative meetings, we had stakeholder groups that came, give ideas, and plans to work with people to make sure that we change the environment. But then once the plan was written, not much happened. And obviously, it's nice to have a good plan and to show a nice document. But if you're going to take it and put it on the shelf and nothing happens, then that's not going to change the outcome. And again, you would see that the outcome, while we have a very good plan, not much has happened with the outcome. And therefore, from the review uh, that PAHO has done, we would like to also now work with stakeholders to develop a new plan going forward from 2021 to 2026. But this one, we want to make sure that we use it. Because if we don't, we'll just be, not impacting on the problem. And really, all these plans are to help us to make sure that we have some sort of impact on the problems before us. So I'm very optimistic that with the partnership with Columbia University, the team from Columbia University, the team from the University of Guyana, other stakeholders, that the new plan that we'll be developing next year, that we will be able to uh, get something that is more responsive to the types of challenges that we have before us. And that's where these studies become very important. Because as I said, we came up with all kinds of factors that we think might be affecting why people commit suicide. And yet we haven't been able to bring down those numbers. A longitudinal study like this one, where we'll be spending about 5 years studying the problem, you don't have to wait until the end. I think periodically you'll be able to get data and use that data to inform how we make decisions. I think that would be very important. And so the annual conferences that we have, the annual discussions that we have, I think would be very important for us to evaluate where we are, what we can do, and if needed, to change course so that we can make sure that we are targeting the right people, the right communities, the right population, and so forth, and the right factors so that we can get results. And I'm very optimistic that the studies that are going to be done certainly going to help us to do this type of work. When we did previous plans, data has always been a big problem for us. The way that we collect data, the way that we classify cases, these things have all maybe cause us to have an underestimate what is really taking place. And then, as you all know, that in some regions we are probably a little bit better in collecting data than others. And so we can see more cases in some areas, while in others, because we perhaps are not collecting the data, it is not available. That does not mean that we don't have cases in those areas. It just means that we are not collecting the data. Or in some cases, it is not being properly classified as a suicide because of our definition. We haven't really formally defined what would be a suicide case. So there's a lot of things that we need to do in this area, and our technical people, we need to train them to be able to understand this field a little more. And again, the partnership that we have here with Columbia, this really is your strength. This particular department of Columbia University, you're bringing epidemiology and psychiatry, which is something totally new for us. We have been doing it more intuitively, but this is something totally new for us. And we would really like to learn from you to be able to get that type of information, that type of training, so that we can improve what we are doing here. And that's how I see this particular type of partnership. In the area of trauma, again, we don't have the type of statistics that we need to have to really change what is happening with unintentional injuries and so forth. We know and we have collected through reports from police about accidents. We have some information pertaining to other types of injuries. But again, our statistical department, we really don't systematically collect information on injuries, people coming into the hospital. I guess at the Georgetown Public Hospital, we might have a little bit more information, but many of the regional hospitals don't systematically collect that type of information. So this particular project, I see it helping us to improve our understanding of injuries in a more comprehensive sense, and allowing us also to use that information for planning purposes. And I think this here is going to be a worthy addition, because when we look at our mortality profile, some of these things, while they're there, it is misclassified, and we don't understand what is happening in terms of getting proper information about the mortality profile. So that's something that I see this particular project helping us and helping to improve what we do. Certainly training in this area and the collaboration between ourselves and the University of Guyana and Columbia University can help to improve our human capacity and certainly help us to improve what we are doing. We are always on the lookout for more opportunities for training, because again, um, while we want to improve the quality of our service, we also need to train more people and retain them so that we can get that quality being improved. We have for many years now started the postgrad program. And again, we want to expand those programs. So it's not only the training that we can do here in Guyana, but also how we can partner with other institutions to give some of the persons who are trained here the kind of exposures in other environments. I think the experience that they bring back is very important, and also it would help to set a different tone, maybe change the culture of what we do here in the standards, because that's what I think some of these exchanges can help with. So the two projects that we have seen this morning and the sub-projects within them, we see these as very important, not just in generating new knowledge for us here in Guyana, but helping to, or helping us to acquire that information so that we can use it to better target the problems that we have here in Guyana. Suicide being the primary one. But we can use that in so many ways, because while we think and we focus a lot on suicide, there are other mental health issues that we haven't even touched on. And those two, I'm sure, as we start explore them some more, we'll probably find that we have quite a high prevalence of those other conditions as well. We meet today, and while we do have a number of persons here in person, I know there are lots more online. And our traditional way of meeting has really been more in person. But the online method has opened up the world to us. And in this particular conference, while Professor Hovind has said that, you know, they really had a short time in which to prepare for this conference. When you look at the conference agenda, the distinguished persons that are going to be presenting over the next couple of days, it shows the reach of Columbia University in this partnership, where we are able to leverage some of the best minds in psychiatry, in some of the fields, not just in the traditional way, but also people who have been doing cutting-edge research, and to leverage that for a conference like this one, and to really lift the quality of what we are doing here. I think while we have started off small, this particular conference is going to set the bar in terms of expectations, what we should be doing with future conferences. So I want to thank and commend Columbia University and the organizing team for the great work that they have done in putting together this conference. So please give them a big round of applause. We look forward to hearing the presentations and, of course, to learn from the presenters of some of the newer things that are happening. I saw in one of the slides that were shown that one of the studies would be doing some interesting thing in collecting saliva. And that perhaps would be added to do some examination of, or looking for a gene that might be associated with suicide. That, I think, is very interesting work. And I mention that because on another piece of legislation that we're working on, we're also going to put new rules in place regarding biobanking. And that one, hopefully, we'll be able to get that through Parliament shortly as well. So it deals with transplantation of tissue and also create new rules for biobanking. So we're thinking ahead because we see a lot of the research that is happening now, and a lot of new things that are coming out is really based on molecular science and the linkages and how, and our understanding generally of disease conditions really changed because of these more in-depth types of research. We welcome that. We want to see more of that type of research happening, and certainly these types of partnerships would help us to do that. My only big ask really with a lot of these things is that I want to see capacity being built here. And again, working with local doctors, clinicians, uh, persons at the university, so that we can be able to build this capacity here. So I think uh, we in the government of Guyana, Ministry of Health, we really look forward to this type of collaboration. We feel that this is going to herald a new era of psychiatry in Guyana. And with this type of collaboration, we can only see things getting better. Professor Hovind, in our preliminary remarks, mentioned that this is a day one, and that from here we can only get better. And I truly believe that, because with this type of collaboration, leveraging the kind of intellectual brain power that is available to us now can only help us to change the conditions that we have here. And we want to work closely with you. The team here in Guyana will be working closely with you. We want that partnership to strengthen, and we want to see this collaboration grow. We don't want it to stop with these two studies. I'm sure that we'll be able to, as we move forward, to look for other opportunities, to develop other funding opportunities, to be able to get other partnerships here. But more importantly, while we're doing all of that, is to work with the local team so that we can expand and grow what we're doing here. We see ourselves as one of the places, one of the countries that should be a leader in the area of health. And if we can be that leader for the rest of the region in mental well-being, then with your collaboration, I'm sure we can become that example. So we want to turn what might have been, a bad thing, suicide and the high numbers. We want to turn that from being such a bad thing to creating new opportunities where we can demonstrate to the rest of the world that the information, the studies that we have done here, the programs that we have been able to implement here can certainly bring optimism and hope so that other countries can follow our example in a couple of years from now and be able to solve their problems as well. I thank you, and I hope that we enjoy the rest of the conference.
Thank you very much, Dr. Anthony. That brings us to the end of the first session of today's proceeding.